there, my name is Lindsay Miller-Byrne, and I'm a PA here in Tehama County. And I have the honor and privilege of knowing and actually working alongside Dr. Wickenheiser for about the last decade and a half. And Dr. Wickenheiser is not only our public health officer, he's a retired internal medicine physician and worked with Lassen Medical Group for over 30 years. I can honestly say that Dr. Wickenheiser is a deeply caring human. He's deeply rooted and invested in our community. He is reasonable, rational, and highly intelligent, and I'm really honored to be able to share some time with him. People that know him and love him and patients over the decades have lovingly called him Dr. Wick, which is why we're called this series Weekly with Wick. The whole point of these conversations is to sort of unpack a lot of the overwhelming data that we're getting with this COVID-19 pandemic and sort of debunk some myths. And Dr. Wick is going to give us some great information to helping understand the numbers. So with that, welcome, Dr. Wickenheiser.
Thank you.
Thank you for being here. So question number one, let's get right into it. Talking about testing, I know there seems to be, as we listen to our community members, a lot of sort of misperceptions of testing. So if you could take a little bit of time to go over again the testing, the different types of testing, and really ultimately who should be tested.
The different types of testing that's available out there include a nasopharyngeal swab, a nasal swab, both done by reverse chain polymerase testing. And what that means is we're actually measuring for the viral particles. We can't tell you if those viral particles are alive or dead, but we assume that if a person is symptomatic early on in their exposure, we assume at that point in time any viral particles that we pick up indicate active disease. After a person has been symptomatic, and if they test positive, we know that after a period of 10 days, that individual still may have a positive test on the PCR testing that we've mentioned, but that individual is not infectious because the majority of those viral particles are no longer alive. So that's one type of testing. We do know that there's newer types coming about, and those tests will include saliva tests, self-administered tests at home, some of those things. And we now have tests like that are being proposed and will be placed in all the skilled nursing facilities so we can continue to monitor there. Those tests will not be available for single use by the individual for probably several months as we look at the public. We may be incorporating some of those testing strategies in terms of monitoring schools. So as people go back to school, the idea is the entire staff gets tested once so we know a baseline. Then what happens is over a period of 2 months, every 2 weeks we measure 25% of the staff. That gives us an idea if we see something occurring within the school setting and if we need to worry about a potential COVID-19 showing up, so we can do something about it very quickly. So the PCR tests tell you you're either positive or negative at the time of the test. If you have a PCR test done on Monday and you do behavior that's not good behavior, you're not socially isolating, you're not wearing your mask, you're going to parties, you're hanging out at the bar, and you get the result back on Friday, and the result says you're negative, that only means you were negative on Monday. It doesn't mean that on Friday, if you were retested, you wouldn't be positive. So PCR testing is the only testing method that we use to tell about acute onset of disease, active disease. The other testing that we have is antibody testing. PCR testing, as we talked about last week, is when a probe is pushed up the nose or the inside of the nose is swabbed. Antibody testing, conversely, basically finger gets pricked, a drop of blood, and we look for antibodies. And what antibodies are, They're proteins that your body develops in response to an infection. And there's two types of proteins. There's an IgG and an IgM. And what happens after exposure to COVID-19, usually within several weeks, a person, if they're pricked, may show an IgM antibody. Conversely, if you wait a short while later, the person now has gone through that phase and they're developing some immunity, so they develop an IgG antibody. Antibody testing is not used to make a diagnosis of an acute infection. Antibody testing tells you that you have been exposed. Now the question is does antibody testing show that you have immunity to the infection? That's a big question at this point in time. The medical community does not know the answer to that. We have seen individuals that have developed immunity and when exposed again have protection. On the other hand, we have seen individuals who have gotten reinfected or disease persists and they don't respond in terms of the antibodies. So therefore, natural immunity from infection in this disease is not the same or does not appear to be the same as you would get if you were exposed to mumps or measles. If you get those diseases, you get antibody protection and you won't get the disease again. This would be more equivalent to getting something like varicella or chickenpox when you're younger. You get chickenpox when you're younger, your body holds it in check. If for some reason your immune system can't keep it in check, it comes out later and you develop shingles. And that may be what we're going to see in this disease. We don't know that for sure. But having an antibody test does not guarantee that you will not get sick again.
Yeah, that's good information. Thank you for that. So just to sort of, I guess, summarize what you were just talking about. So the nasal swab and the nasal pharyngeal swab will give us, it's a PCR testing, so that's going to tell us active infection, correct?
Correct.
Now the antibody testing is going to show very, very recent or a little bit longer exposure to it. So that's what our bodies naturally develop. Our immune systems develop those IgM and IgG as a response to being exposed to that virus.
That's correct.
So the differences of the two tests, the PCR versus the antibody, do you have a recommendation for if or whom should be tested for either PCR or the antibody?
At this point in time, the only test that we're recommending is the PCR testing because, again, we're doing surveillance within the community to see the extent of disease in the community. We want to be able to test and track active cases and deal with their contacts. We will probably be suggesting antibody testing late in the fall when we do influenza vaccination. The reason being is by that time, there'll have been enough COVID-19 in the community. It would be really helpful to see what percent of the population has already been exposed. Because many people get exposed, don't know they're sick, and don't know they got better because they didn't know they were sick. So by doing antibody testing later on, it is going to help us strategize as we talk about vaccinating people. For instance, if somebody's been exposed, has a prominent antibody experience, then that individual may not be high on our list to give the vaccine first. We may elect to give those individuals who do not have any antibody response at all and have underlying health conditions that make them much more vulnerable to it. So that's the way we're looking at antibody testing. So eventually I think you will see that antibody testing will become widespread. And you've already seen it happen in like the state of New York and New York City because they had such widespread disease. If you start doing antibody testing, you can then tell what percent of the population was really ill. I will tell you that In May, there was a large study that was done in Marin County by UCSF. And at that point in time, Marin County was a hotbed of COVID-19. Yet, when they did antibody testing, less than 0.5% of the community had antibodies to COVID-19. So therefore, I think the myth is that just because you have a lot of COVID-19 in the community, you cannot expect that everybody will have an antibody response to the disease. Hence, you can't say because there's been a lot of disease in the community, everybody should be immune to COVID-19.
Hopefully you can shed some light on this. I know I've heard it a lot of times in the community. I was sick as a dog 3 months ago or in January. I know without a doubt I had COVID-19. I had all the symptoms. So I want to get the antibody testing so that I know I don't have to worry about it anymore. So you can help, hopefully, all of us unpack that a little bit.
Sure. That actually comes up fairly frequently, and the medical providers feel very frustrated as they're dealing with the patients. We know that so many other viral illnesses mimic COVID-19, and I can tell you personally, and looking at the data that we've seen in Tehama County, one clinic in particular, I think there are now over 65 antibody tests that they've done, and they're only doing antibody testing on people that come in with that scenario that you've just described. I've been sick as a dog. I know I had this. I just know it. And I can tell you, of those 65 tests, only 2 of them were positive. So that tells me that you as an individual are not able to distinguish whether you had COVID-19 or not.
Yeah.
So, just doing the antibody testing is not going to be helpful. Again, if a person is ill, early on we did not have enough testing to test everybody that's ill. If a person's symptomatic though now, there's no reason why you can't get a PCR test and we can tell you, yes, you have COVID-19 or no, you don't have COVID-19.
Right. Okay, so in short, if you could summarize again who you believe and recommend should get tested and how frequently. I know we addressed it briefly last week, but it's always nice to sort of recap.
Sure. Once again, I think it's very important to know where we're at community surveillance-wise. So as I had mentioned before, I think that it would be great if everybody in the community got tested at least once. There are certain individuals based on their risk situation and stuff, such as EMTs, healthcare people, people working in nursing homes, teachers that will be testing on a more frequent basis because of their exposure. But if everybody got tested at least once, that would be great. Also, if you're symptomatic, please get tested. And our LHI site, the OptumServe site, that's very easy to schedule an appointment for. You just go online, you get yourself a number, you go in there. Everything is scheduled block times, so you might get an appointment at between 7 and 8, but I can tell you that you'll spend no more than 2 or 3 minutes there. That's all the longer it takes to get your test done. We, of course, recommend, just as the governor said, everybody should mask. You should show up at the site wearing a mask. They will take your mask down when they do the test. But those are the people that really should be tested. So whether you're asymptomatic and we're doing it for community surveillance, or whether you're symptomatic and need to know.
Okay, great. And with regard to testing, I've also heard a lot of variability in getting results back. Some patients and friends in the community, I've heard they've gotten results back in 3 to 5 days. Other people have been 17 days. So with you being sort of on the pulse of it, do you anticipate or have a better understanding or maybe an introspection of when that time frame is going to be more consistent and short?
The state has a testing task force, and that testing task force has been working really hard on this. What they've done is they've identified additional labs other than Quest and LabCorp who are doing the bulk of the tests. And if we can get things to work out, what's going to happen is they'll be pushing those out to other labs too, so that things can be done in a more timely fashion. Because as we talked about before, getting the test results back 7 days, 10 days, 14 days after you have them done, they're not helpful unless
Right.
they're negative. But if they were positive, it's not given public health a chance to intervene, to stop what's going on, and to move forward with things. I can tell you that the goal at the state level is to have the test turn around in 48 hours. That's what they're looking at. Again, once we see the rapid at-home tests and stuff, those you'll have results almost immediately, but those are several months again down the road from here.
That's encouraging information. I think, with the that we're in right now, there's also sort of the ask for grace, because I know that this is new for all of us, and so, which is why we've seen a lot of variability in getting those time results back. I'm excited that the nasal swab will also be available, and that hopefully we can get results back in 48 hours. That will be ideal. So ultimately, you're saying, let's have everybody get tested at baseline, and if you are high risk or high contact, to get tested more frequently. Would you recommend, if you are somebody, like in the medical field, for example, or an essential worker, would you recommend or suggest every 2 weeks or monthly? What would be a rough recommendation?
That all depends on what your job is and what your risk exposure is. Mm-hmm. So if your risk exposure is fairly minimal, even though you're an essential worker, it would not make a lot of sense to keep getting tested. If your risk exposure is high, because you find yourself in a situation such as a paramedic having to do something
Right.
with somebody, and you show up on the scene with a surgical mask, and this person is spewing all kinds of COVID-19, and you didn't have an N95 mask on, that's a whole different situation. Right. So I think we have to look at each of those individually. We have written some guidelines for essential personnel, healthcare workers, how often they should be tested. So you can always refer to the local public health department, and we'll help you kind of work your way through that.